Introduce our speakers for this morning. But before doing that, I'd like to do our land acknowledgement to remind us that Ottawa is built on unceded Algonquin Anishinaabe territory. The peoples of the Algonquin Anishinaabe Nation have lived in this territory for millennia, and we honor them and this land. Their culture and presence have nurtured and continue to nurture this land. CHEO also honors all First Nations, Inuit, and Métis people and their valuable past, present, and future contribution. So I'm very pleased to be introducing two colleagues of mine in pediatric emergency medicine to give grand rounds this morning. The first presenter is Dr. Graham Thompson, who's an assistant professor and pediatric emergency physician in the Department of Pediatrics at the Alberta Children's Hospital and affiliate of the Alberta Children's Hospital Research Institute at the University of Calgary in the Faculty of Medicine. So Graham is a pediatric emergency physician at Alberta Children's Hospital and the Canadian primary investigator for the upcoming PROMPT BOLUS study, which he may be speaking about today. He's an avid outdoorsman and spends as much time as he can running in the mountains and encouraging everyone to enjoy being outside. And I fully expected during this lockdown period, Graham would show up in a full-on grizzly Adams beard and maybe from a mountaintop somewhere. So I'm glad you seem to have good Wi-Fi connection today, Graham. So thank you for being here. Our second presenter is well known to us all, Dr. Fuad Alnaji. So Fuad is an assistant professor in emergency medicine pediatrician at CHEO, as well as a critical care physician at CHEO. He received his medical degree from Arabian Gulf University in Bahrain before beginning his residency at the National Guard Hospital in Riyadh, Saudi Arabia. He then moved to Canada and completed his pediatric residency with us at CHEO, and then went on to complete subspecialty training in pediatric critical care medicine and pediatric emergency medicine. His academic interests include transport, trauma, resuscitation, and medical simulation. His major focus, Fuad has a major focus in transport medicine, functioning as a physician with Orange Transport, and is pursuing research in the areas of pre-hospital resuscitation and transport medicine. So today, Graham and Fuad are going to help us to consider whether we should have been listening to the surgeons all along. Their presentation today is called Resuscitation in Children with Sepsis, Rethinking Our Reliance on Normal Saline. So over to you, and I believe Graham will be starting with us.
Thanks, Mona. I think I'll start and then we'll go.
Okay. Great.
All right, let me just share my screen. Right, can you confirm that you see the slides? All right, so thanks, Mona, for the introduction, and thank you all for joining us today. So Graham and I are excited to present some work that we're hoping to start soon at CHEO, and we're hoping to introduce some of the evidence on this. So before we start, we're going to start, Yeah, we have no conflicts of interest to declare today. I will start with the case at the beginning here. So this is not an uncommon case that we see in the emergency department. So this is a 4-year-old boy who comes in with fever and vomiting. It's a season, viral season, a lot of fevers, a lot of vomiting. And when assessing this patient, their airway is patent. They're breathing fast at 40 breaths a minute. They're saturating 90% on room air. They have crackles and decreased air entry on the right side with evidence of increased worker breathing. The patient is tachycardic with a pulse of 150, a normal blood pressure of 95/65, a temperature of 39.5, but has weak peripheral pulses and a delayed cap refill of 6 seconds with cold extremities. The patient opens eyes to voice, and a sugar check shows a sugar of 5.5 with no obvious rash. So if you see this patient in the emergency department, so what do? What's next? Before we get there, we're going to review our objectives of the presentation today is to review fluid resuscitation in sepsis, mainly focusing on recent studies related to saline and balanced fluids, then describe the upcoming international BOLUS study. So what do we do to resuscitate these patients coming in with suspected or proven sepsis. The goal is to support them and in a rapid way. So within an hour of the initial recognition of shock, like in this patient who presents with a compensated septic shock with high fevers, normal blood pressure, but evidence of delayed cap refill and cold extremities, as well as an abnormal level of consciousness, is to get an IV earlier on. And if you can't get one, get an IO, get cultures if you can, start empiric broad spectrum antibiotics quickly, measure evidence of biochemical tissue perfusion like lactate, and give fluids if shock is present. And if shock is not reversed with fluids, then start some vasoactive agents. So this is an earlier study from 1991 showcasing the role for early fluid resuscitation in pediatric septic shock. So small study, but it's good to see that, since the early 90s, we had some evidence that fluid administration is actually helpful. So small study looking at kids that presented with septic shock that received less than 20 per kilo of fluids, 20 to 40 per kilo of fluid, or over 40 per kilo of fluids in the first hour, with a significant survival benefit in the people that got over 40 per kilo of fluids, with decreased percent hypovolemia and no increased evidence of pulmonary edema or ARDS. Again, a small study, but it was the beginning of showcasing the importance of early fluid resuscitation in these patients with septic shock. This was followed over the years by many studies showing that giving fluid early in these patients makes a huge difference in their outcomes. Before we proceed, it's good to review the relative fluid composition between blood as compared with saline or balanced fluids like Ringer's lactate or plasmolite. So I'll draw your attention to the chloride content comparing blood with saline. So blood has a chloride level between 95 and 105, with about 100 as an average. Saline has 154 millicurie chloride versus Ringer's or plasmolite has close to what the blood has from a chloride content. And if you look at Ringer's and plasmolite, they both are buffered solution, one containing lactate and the other containing acetate as a buffer. And the pH measured in those fluid solutions are closer to blood compared to saline, which is more acidic. And then the strong ionic difference in those solutions is close to blood. So looking at our patient here that we anticipate is we're going to require a lot of fluids as they're coming in with septic shock. What if you open the floodgates here? What would happen? And what are the effects of what we do on our patients? Whenever we give fluids here, whether it's given saline or balanced or buffered solution, we know that crystalloids are the fluids of choice in those patients needing fluid resuscitation. And our goal is to restore circulation and reverse shock. But at the same time, we have to think of what would be the undesired effects of those solutions on our patients, like hyperchloremia, metabolic acidosis. Is there an effect on vascular permeability, kidney perfusion, splanchnic ischemia or perfusion issues, coagulopathy, or inflammation? And then secondary to those, is there going to be an issue with fluid overload, acute kidney injury needing dialysis, infection risk needing transfusion? What is the length of stay or mortality risk in those solutions as compared, whether it's saline or versus balanced or buffered solutions? This is an interesting study published in Annals of Surgery in 2012 that looked at healthy volunteers who received 2 liters of fluids, and they randomized them to saline versus plasmolite. So if you look at this graph here, it showed the serum chloride level comparing sodium normal saline versus plasmolite, and you can see a higher chloride content in the saline group on the top here. Same thing with a higher ion difference in the saline group, but also I think this is probably more relevant to us here at the bottom, showing that the saline group here in the bottom has lower mean artery flow velocity, probably related to decreased kidney perfusion. And probably secondary to that, also we have the renal cortical tissue perfusion was also lower in patients who received saline. This is another study that compared patients in 4 New Zealand ICUs that received saline versus Ringer's lactate. And this was a pilot study to try and plan for another bigger study, but it was about 2,000 patients, mostly admitted to the ICUs for elective surgery. And about 4% of them had sepsis. It actually showed no difference in needing renal replacement therapy or mortality risk in both groups. So there may be some equipoise over here, especially in those patients. Another 2 important studies that are landmark studies looking at balanced crystals versus saline in patients that are ill or not critically ill or critically ill needing ICUs. So both those studies were published in New England Journal of Medicine in 2018. And the study on the left here looked at over 13,000 patients that came to the emergency department and later on admitted to the wards. And the study on the right was looking at patients that, about 15,000 patients that were later on admitted to the ICU. And these were done in Vanderbilt. Vanderbilt has 5 ICUs, and you can come in from the ED, come in from the OR, or any other place that will lead you to the ICU. That both actually showed decreased odds ratio for this outcome called MAKE 30. So we're going to talk in more detail later on about this MAKE 30 outcome. And it's a composite outcome looking at 3 variables, looking at mortality, new need for renal replacement therapy like dialysis, or persistent increase in markers of kidney injury, like doubling creatinine that stayed high at 30 days. And both showed decreased adjusted odds ratio for MAKE 30 or hospital deaths in both studies. If you look at the subset of patients that had sepsis, there was a stronger signal for favoring the balanced crystalloids over here, with a lower odds ratio for this MAKE 30 outcome in the patient with sepsis. And these patients probably had an increased fluid need related to their presentation. Another interesting study here looking at just the effect of chloride and what chloride may do to the kidneys. So this is a secondary analysis of another study that looked just at a chloride level and whether chloride level had an association with acute kidney injury. So if you had a minimum chloride or a mean chloride of over 110, you had an increased adjusted odds ratio for stage 2 or stage 3 acute kidney injury, and also an increased odds ratio of mortality. Unfortunately, this study did not look at confounders or comorbidities and how much fluids these patients received. 2 other studies here looking at, these are database studies that one on the left here looking at over 4,000 patients in community hospitals. And the one on the right looked at over 7,000 patients admitted to academic PICUs. And interestingly, balanced fluid resuscitation did not really change or showed an improved outcome in patients who received balanced fluids, Ringer's lactate, if you were in a community hospital. But this was not the case if you actually were admitted to an academic ICU, probably because of a sicker patient subset here, but definitely had an adjusted odds ratio that was lower in these patients that were admitted to academic PICUs. Are balanced fluids safe? Although the available physiologically balanced fluids contain, a chemical composition that's closer to blood, nothing really is balanced or physiologic. The main worries are related to the effects of balanced fluids because they had lower tone or lower osmolar gradient compared to saline. Are they going to affect brain? Are they going to have, because some of them have a bit of potassium, is it going to cause hyperkalemia? And because of the lactate present in lactated Ringers, is it going to cause hyperlactatemia? Two idle studies here looking at mainly actually at the chloride level and acid or pH level in patients that had traumatic brain injury. And both showed less chloride and less effect of acidosis if you're given these patients Ringer's lactate as compared to saline. And interestingly, the mean difference of sodium levels in both patients who had a TBI, whether they received saline or blood, actually was, they had the lower sodium levels of about 2. Just to note that the recommendation, if you have a patient with a traumatic brain injury, is still to give saline. Because of that risk of dropping the serum osmolality or sodium levels. But just to note that these patients may actually be more acidotic if you give them a lot of saline. What about the effect on potassium? Although these solutions may have have a small amount of potassium levels, a lot of RCTs in patients who were undergoing renal transplantation or have kidney dysfunction have shown actually less hyperkalemia with balanced fluids. And it's probably related to less acidosis causing hyperkalemia. What about the effect on serum lactate levels? We know that lactate Ringers actually can increase serum lactate levels a little bit, but this will not be harmful to patients' outcomes. The lactate present in Ringer's lactate is sodium lactate rather than lactic acid. And it should not really alter on its own significantly the serum lactate levels. This study looked at healthy volunteers that received 30 per kilo of saline versus lactated Ringers. And actually, the saline group had about a 0.3 increase in serum lactate levels, and the lactated Ringers patients had about a 0.9 increase in serum lactate levels. But both, this was not statistically significant for both groups. And interestingly, the saline group had a lower pH as compared to the lactated Ringers. And the feeling here is that if you actually have serum lactate that's high, this is related to anaerobic metabolism and tissue perfusion. And if you replenish the tissues and deliver oxygen and nutrients to the organs, you actually would have a drop in serum lactate levels because of the volume resuscitation. So how about cost? The cost of saline is about $1 per liter in the US. I'm not sure how much is it in Canada. Ringer's lactate is about $1 per liter. Plasmolite is about a couple of dollars, $2 per liter. So there's, in the grand scheme of things of how much healthcare is costing, the cost of a liter bag of saline versus Ringer's versus Plasmolite is almost similar. So going back to the Surviving Sepsis campaign that looked at the evidence of fluids. And for the first time in 2020, they are suggesting balanced crystalloids rather than saline for resuscitation of children with septic shock. But this was a weak recommendation with very low quality of evidence. And this is a recommendation pending further high quality pediatric data. And there's a knowledge gap and research opportunity that should look at balanced crystalloids versus saline. So this brings us to our study here. So I'll hand it over to Graham here. And Graham, just let me know if you need me to move the slides. After you, Grant.
Great, thank you so much. So I'm excited to be able to join you today to chat with you about the prompt bolus study. And if we could just move to the next slide there. So the excellent description that we just heard from Fuad is a little summary of what is happening in terms of the background research related to the clinical equipoise that exists to decide the optimal fluid for resuscitation in pediatric sepsis. And so we ask the following research question in prompt bolus. In children aged 6 months to less than 18 years who present to the emergency department with septic shock, does resuscitation with balanced fluids improve clinical outcomes compared to resuscitation with normal saline? So just as a quick summary, to address this question, we designed an international, pragmatic, randomized controlled trial of children aged 6 months to less than 18 years presenting to the emergency department with septic shock. While enrollment of the study occurs exclusively in the emergency department, the research activities will be extended to both the hospital wards and the PICU. We are comparing balanced fluids to normal saline in an open label design, and the primary outcome is major adverse kidney events known as MAKE30, which Fuad described previously. Our anticipated enrollment period is about 4.5 years. So Prompt Bolus is a collaboration between 3 pediatric emergency networks, PERC, PCARN, and PREDICT. These 3 networks represent 4 countries, including Canada, the United States, Australia, and New Zealand. The study is funded by the respective national health research funding agencies, including our own CIHR, the National Institute of Health, and the National Health and Medical Research Council of Australia. Together, we anticipate enrolling 8,800 children. And to our knowledge, this will be the largest international acute care pediatric RCT that has been performed. So what does this look like here in Canada? Pediatric Emergency Research Canada, known as PERC, is an established network of highly invested Canadian researchers in resuscitation-focused emergency medicine and critical care. It is a premier research network of 15 Canadian children's hospitals that is dedicated to improving care through multi-center research. PERC has developed a core infrastructure to support sepsis-related RCTs. The track record of this network of high-quality clinical trials and publications has been recognized with a CIHR CMAJ Top Achievement in Health Research Award. Together, PERC sites manage over 600,000 patient care visits annually. For the Prompt Bolus study, 13 sites will be participating. This includes the host site, which is Calgary, Vancouver, Edmonton, Saskatoon, Winnipeg, London, Hamilton, Toronto, Kingston, Ottawa, Montreal, Quebec City, and Halifax. The primary objective of our study is to determine if fluid resuscitation with balanced fluids will improve clinical outcomes, specifically major adverse kidney events, or MAKE30, compared to fluid resuscitation with normal saline in pediatric septic shock. Relying on mortality alone as an endpoint in pediatric sepsis is limited. That is because it has a low relative incidence in children compared to adults, and because it does not take into account the potential end organ morbidity that these children experience for long term. MAKE30 is a composite endpoint that includes death, new renal replacement therapy, or persistent kidney dysfunction which is defined as the last creatinine before discharge or at 30 days at 200% baseline. MAKE 30 does not require serial creatinines or urine output assessments. It is associated with long-term chronic kidney disease and long-term morbidity and mortality. So how exactly does this apply to children with sepsis? How often are we seeing an outcome of MAKE 30? In this retrospective observational study of pediatric health information systems, which is called FICE Plus hospitals, and there are 6 of them in the US, this study evaluated 1,685 sepsis encounters in 1,460 unique children. Overall, the rate of MAKE 30 in children managed for sepsis was 9.6%. This rate is very similar to the rate seen in the young participants of the SMART study, which Fuad had mentioned earlier, one of the studies from Vanderbilt. This rate of 9.7 in those individuals aged 18 to 21, which are closest to our pediatric population, is very similar to what is seen in this pediatric FICE Plus hospital. Death occurred in 4.5% of children. New renal replacement therapy occurred in 1.7% of children, and persistent kidney disease in 5.8%. Our secondary objectives are to evaluate the effectiveness and safety of balanced fluids versus normal saline in pediatric septic shock. These endpoints include hospital mortality, length of stay, hospital-free days, new renal replacement therapy, persistent kidney dysfunction, mortality at 90 days, hyperlactatemia, electrolyte abnormalities, thromboembolism, and cerebral edema. So practically speaking, what will this study actually look like? Identification of these patients will occur in the emergency department by ED clinicians. This is a pragmatic trial, and we will rely on clinicians throughout the study. Bedside enrollment will be performed by ED clinicians, and the control group, if eligible, will have normal saline, which is the current usual practice. The intervention is balanced fluids, which is Ringer's lactate or Pedialyte, Plasmolite, not Pedialyte. Study fluids will be maintained through midnight the following day, and then outcomes will be assessed. Our inclusion criteria will include children aged 6 months to less than 18 years of age who have presented to the emergency department with suspected septic shock. This includes those children who have had a blood culture performed, are receiving parental antibiotics, and have received at least 20 milliliters per kilogram of fluids for abnormal perfusion. Practically speaking, sites that have sepsis pathways in which the child meets the criteria for the sepsis pathway and the child receives 1 bolus will be eligible for the study. We are excluding those children who have had more than 40 mils per kilo of fluids, or in whom the clinician judges that it is unsafe to participate in the study. Some criteria include suspected brain herniation, known electrolyte abnormalities, known severe hepatic or renal failure, and known metabolic or mitochondrial disease. We will also exclude those children who have known pregnancy or are hypersensitive to the fluid resuscitation. The randomization in this trial will be performed using serial numbered opaque envelopes. We will select the next in line to perform our allocation. Randomization is being done in 1-to-1 permutated blocks and stratified by site. The study intervention is solely the type of resuscitation fluid that is provided. The intervention, balanced fluids, can be either Ringer's lactate or Plasmolite. This is based on the physician choice and local practice. Additionally, Plasmolite and Ringer's lactate can be interchanged based on the managing physician's choice. The control is normal saline. Of note, this is an unblinded study. It is open label. The fluids for this study include all bolus and maintenance fluid. We do not control the volume, the frequency, or the timing of fluids. these will be left to the discretion of the managing healthcare team. Study fluids will be provided until midnight the day after enrollment. This was chosen as a pragmatic endpoint because the SMART study demonstrated that 75% of crystalloids were administered within the first day of admission. We do want to make note that clinical teams should take caution and check compatibility of medications and blood products, especially those containing calcium, and use according to local standards, such as second lines or flushing practices. In keeping with the ongoing nature of the study, all clinical care outside of the study fluid allocation is at the discretion of the managing healthcare provider. This means that additives such as dextrose and electrolytes can occur as per standard of care in the institutions. If clinically indicated, the use of alternative fluids can be provided and will not be considered a protocol deviation, as this would occur even in regular practice. There is no requirement in this study for extra labs, extra imaging studies, or specific data collection tools to be performed in the clinical setting. To assist clinicians in the study processes, we are suggesting that sites make use of a sepsis cart. A sepsis cart is not formally part of the study, as it might not fit into all the current practices of different sites. But we do suggest that people are able to put all the required study and clinical equipment to resuscitate a child into one specific place. This improves the ability to have everything together at the same time and not need to run off to different rooms to find research material during the middle of a resuscitation. Sites are encouraged to modify the cart contents based on local practices. However, some things that can be included are the study materials with eligibility charts, randomization envelopes, information about handover to admitting teams, obviously the allocation fluids, including normal saline and balanced fluids, and then regular supplies that may be used by the clinical team for sepsis management. As I mentioned, the addition of other fluids can be used if clinically indicated in the patient's situation. Therefore, we wanted to make sure that protocol adherence was not defined as absolutely 100% all fluids being according to the allocated fluid. Protocol adherence will be defined as administration of at least 75% of all fluids received during the intervention window that is in keeping with the allocated fluid at randomization. If 80% of participants, less than 80% of participants meet this criteria within a month period, there will be specific targeted education to improve the these results and help the clinical teams in their processes. Similarly, if less than 80% of eligible participants at a site are enrolled within a month, there will be targeted education. And if that enrollment drops below 70%, the Data Safety Monitoring Board will become involved to address challenges at the individual sites and implement solutions. Because of the time-sensitive nature of protocol, including rapid identification, rapid recruitment, rapid randomization to fluid treatment arm, and then the rapid need for fluids, antibiotics, and identification of sources, this all needs to be done in the ED resuscitation, and it is truly impossible to obtain informed consent in these situations. Fortunately, we are guided by the TCPS2 Article 3.8, which allows us to have consent for research in individual medical emergencies. The specific criteria for deferred consent include a serious threat to the prospective participant that requires immediate intervention. Either no standard of efficacious care exists, or the research offers a realistic possibility of direct benefit to the participant in comparison to the standard of care. Either the risk is not greater than that involved in standard efficacious care, or it is clearly justified by the prospect of direct benefit to the participant. The participant is unconscious or lacks capacity to understand the risks, methods, and purposes of the research project. The third-party authorization cannot be secured in sufficient time, despite diligent and documented efforts to do so. And finally, no relevant prior directive by the participant is known to exist. Following enrollment, the clinical team of the Prompt BOLUS study will provide the families with an information sheet notifying them of the study and informing them that a member of the research team will be speaking with them at a later time. Canadian pediatric emergency departments and PICUs have used the deferred consent model in previous sepsis studies, including the Alberta Sepsis Network studies, which were bioscience studies in children with sepsis, and the most recent study, the SQUEEZE trial, which was performed at 6 sites across Canada and led by Melissa Parker in Hamilton. We look forward to the results of a qualitative sub-study of the SQUEEZE trial that evaluates the experiences of substitute decision makers related to the deferred consent model. Data collection in this study will be very brief. It will be obtained from the clinical record. All the data will be collected by the research team, and the clinical staff is not responsible for collecting additional research data. Canadian data will be collected using a custom REDCap database, which is hosted by WICRI at the University of Alberta. The overall study data coordinating center is housed by the Children's Hospital of Philadelphia. Targeted adverse events assessments will be performed at days 2 and day 7. So I mentioned before that our sample size is 8,800 children. This is a very large study. How did we arrive at that sample size? So our sample size was calculated using data from the previously mentioned FISE+ study, along with administrative data from Children's Hospital of Philadelphia and Colorado Children's Hospital. At these sites, the rate of MIC30 was between 5 and 9.6%. To be conservative, we estimated a rate of MIC30 of 6%. Given the relative risk reduction from the SMART trial, including those people 18 to 21 years of age who are closest to our population in terms of age, and assuming that a 95% alpha and a 95% power and a 0.05 alpha, we will need 4,400 children in each arm, which creates our total sample size of 8,800. It is estimated that suspected sepsis represents approximately 0.125% of all ED visits, enrolling 80% of eligible patients. Therefore, we anticipated that an annual enrollment at CHEO will be approximately 70 patients. Because sepsis outcomes differ by age, sex, and cancer status, we will perform subgroup analyses on these populations. Furthermore, because crystalloids have key biological effects on kidney function, we will anticipate that the presence of acute kidney injury at the start of sepsis resuscitation will modify the effect of fluid type on outcome. We will also assess the impact of total fluid volume that was administered. Finally, we will evaluate the effect of country of enrollment to account for regional practice variations. While Prompt BOLUS is an emergency medicine-led study, we truly rely on the collaboration of our PICU, hospitalist, subspecialist, and OR teams once the children have left the ED. We developed a process to make sure that the communication and protocol handover will be as easy as possible, including IV poll notifications, color-coded randomization bracelets, door hangers. There is the possibility of using EPIC order sets, as I understand that CHEO has an EPIC data platform. However, we do recognize that each site has their own specific policies and procedures, and we anticipate that each site will adapt these study aids to make use in their environment. So why do we need to care about this? What is the importance of this study? Unless we care, and unless we do something about it, nothing is going to get better for these children. Based on a study by Scott Weiss from Children's Hospital of Philadelphia, A positive result of our study will result in 1,275 fewer cases of MAKE 30 per year, 242 fewer cases of chronic kidney disease per year, 50 fewer deaths per year, and $35 million less in healthcare costs in the United States. If we extrapolate this out to the other countries participating and then globally, this could be an immense outcome improvement for children with pediatric sepsis. So where are we right now with this study? For our PERC sites, we have approved approval from Health Canada. We also have approval from the University of Calgary Research Ethics Board. Currently, sites across the country are working on their own REB submissions, including a CTO submission. We're developing our legal contracts. Right now, a DTA has been arranged with the Children's Hospital of Philadelphia, which is the data coordinating center for the 4 countries. We are currently working on our PERC site contracts. REDCap database testing is in progress, and we are developing our site monitoring plans. We expect to start recruiting in late October at the Alberta Children's Hospital, and we are hoping that other sites are able to join us later in the fall. In relation to our partner networks, the PCAR network has 12 sites currently enrolling, and the PREDICT network has 2 sites currently enrolling. To date, 315 participants have been enrolled. So as a quick summary of the BOLUS study, this is an international, pragmatic, randomized controlled trial of children 6 months to less than 18 years of age with suspected septic shock. The enrollment occurs in the emergency department with extension to the wards and the ICU. Our intervention is balanced fluids versus normal saline in an open label design. The primary outcome is MAKE 30, a pragmatic and clinically relevant research outcome. We'll be performing this study over the next 4.5 years. I'd like to particularly acknowledge the work of our international study leads, which is Dr. Fran Balmuth and Dr. Scott Weiss from Children's Hospital of Philadelphia. Also like to recognize the contributions of the PREDICT team in Australia and New Zealand, Drs. France Babel, Stuart Dalziel, and Elliot Long. Also like to recognize my co-PI for the PERC sites, Dr. Stephen Friedman, our national coordinator, Sarah Urquhart, and all the pediatric hospital medicine and critical care teams. In particular, a special shout out to Drs. Fuad Alnaji and Walid Al-Qureshi from CHEO Emergency Department and Critical Care, and also Lauren Dawson, who is the coordinator at CHEO. With that, I'd be happy to answer any questions about the study and about our topic of balanced fluids versus normal saline.
Okay, great. Thank you very much, Graham and Fuad, for that great presentation. We look forward to this trial and the findings that are going to come from this trial. And we see our very own Roger Zemek is the first with his hand up, so I'll turn it over to Roger. Question for you, Roger.
Hi, Graham and Fuad. It's great to see both of you and great to see another PERC study presented here. One question I had was, I know often we are faced with challenges of finding the right balance of feasibility, convincing peer reviewers. I saw that your study took a very conservative approach to the estimates, but also took a conservative approach to the power, and it was 95% power. And I was curious how you went around that as compared to other studies which have either an 80 or a 90% power to detect a difference if one is there, because that obviously will increase your sample sizes by quite a large factor.
Yeah, so I'll just address that. Thank you, Roger. We really appreciate the support of our PERC network. I'll say that first, and thank you to you as our lead of the PERC network and everything that all our sites are doing for this. So the 95% power was selected for 2 reasons. The Data Coordinating Center and the DSMB felt that because there was a very small anticipated absolute risk reduction, and the overall initial rate of MAKE 30 and of the subgroups of the MAKE-30, including death and new renal replacement therapy and chronic kidney dysfunction. And then associating that with a low risk for a type 2 error, they felt that going with a very conservative higher power was appropriate. And it was, I think, mostly to address the fact that that absolute risk reduction that's anticipated is quite small.
Great. Thank you. Next question to Dr. Sarah Reed. Sarah?
Hi, Graham. Great job.
Hi,
thanks to you and Fuad. This is really exciting. I'm just wondering, could you just clarify the exclusion criteria? The first one you listed was more than 40 per kilo given. Does that mean the more than 40 per kilo given prior to randomization, or?
Yeah. So yes. So this is actually a really important point because some people have concerns that. It will be difficult to reach a sample size of 8,800 if we are exclusively enrolling very, very sick children. So in all the studies that are looking at sepsis in children and outcomes, we know that it can be very tricky in the resuscitation room or in an emergency department, sometimes in other rooms, to identify those children who will go on to have rapidly deteriorate and have severe disease. And so what we're trying to say is if you have given a bolus and antibiotics and suspect infection, and you anticipate that you're going to have to give another one, that's the moment that you want to actually identify these children and start enrolling them. So if they come into the resuscitation room and you're convinced that this child is going to need 40 to 60 to 80 mils per kilo, you can start randomizing them at that point right there. Start your initial fluid bolus and go ahead. If you have one of those children who may not be quite as ill, and you're giving them a bolus and you anticipate that you're giving a second bolus, and so you randomize and they're eligible and they're in the study and they do not get that second bolus or third bolus, that's still okay. They've met the eligibility criteria. However, speaking to the exclusion criteria, as you mentioned, if they've already received over 40 per kilo, at that point in time, they're no longer eligible. And that includes those children who have received fluid from the transport teams coming in or from the EMS teams bringing those children in. If they've already received more than 40 per kilo, or there's an unknown number in terms of how much fluid they have, and you're starting rapid resuscitation, at that point, they are no longer eligible. And that was put in to make sure that the pre-study fluids do not have a significant washout effect of the study medications later on.
Okay, great, thank you.
I don't see any hands raised right now, so I have a couple questions for you both. Just practically speaking, if you're at that point between the, you've given a bolus, how quickly are you able to enroll a patient to do that randomization and enroll a patient given the setting? And you did talk about the consent process being different. But can you just discuss that? Because sometimes there isn't a lot of time.
Absolutely. And that's why the deferred consent method has been approved by UFC, and we anticipate it will be approved across the country. So, of course, these children need rapid resuscitation, and sometimes it's bolus after bolus right on top of each other. And so that's why we're saying if you are anticipating giving a second bolus, then you can start the process right away. So what we've tried to do to make it as easy as possible is the suggestion of the sepsis cart. And so all materials that are required for the clinical resuscitation of the child and the research are together in one spot. Hopefully it will be exceptionally easy to just pull out a package that goes through the eligibility criteria, pull out your randomization envelope, and then start the study based on that fluids. So in terms of why we're using envelopes versus an electronic randomization process, such as randomize.net, This was actually one considering factor. People didn't want to actually have to go away from the resuscitation to perform a randomization on a computer and then come back, wasting valuable clinical time. And so having those quickly available with pre-printed randomization envelopes is going to improve that. So an estimate based on the current 300 plus patients that have been enrolled in this study, the PCARN network has told us that the whole process from identifying to actually starting the fluids after they've been allocated ranges between 3 and 5 minutes. So it's pretty rapid. And again, if you know that this child is severely ill, you've started your initial first bolus, you're getting a second line and about to start your second bolus. If you start doing that at the same time because you've anticipated rapid multiple fluid boluses, then you're already on the same process. If you have one of those children that's maybe a little less sick but has compensated septic shock and they're not in the recess room, then you do have a bit more time to go about getting the materials ready. One example would be a child with sepsis related to appendicitis, and they have SIRS criteria. They're getting managed for their compensated shock, and you're delivering fluids for the purposes of abnormal perfusion, not for the purposes of dehydration from vomiting or not eating, but it's clearly for clinicians' decision of abnormal perfusion. You have a bit more time in those circumstances.
Great.
Just to follow that, like, you know, our goal is to rely on our emergency department staff to enroll this patient, whether it's 2 in the afternoon or 2 in the morning. Hence the discussion here, and we should have a lot of champions in the emergency department to support this research.
You definitely have a lot of champions there. I have one more question because I don't see any other hands up right now. One more question. So this trial is really focusing on exclusively the type of fluid that's being used, nothing about the amount of fluid, how quickly it's given, how quickly you go to steroid, et cetera. It's really focused on just the fluid.
Absolutely. The only thing that we are controlling is the fluid type. So all of those things, like when you give fluids, how much, the timing of vasoactive medications, any ancillary therapies associated with managing a septic child are all up to the discretion of the managing team. And so we hope that this is a very easy and pragmatic trial to run and get going in the departments. We do know that there are some other studies that are going on across the different sites, and we're working with those studies to make sure that we are as compatible as possible to do co-enrollments when it's possible. And so we'll be working with all those teams to make sure those are going. I'm just going to jump on one quick note that to follow on what Fuad had mentioned. The clinical team is vital in this study. We do not have research team members enrolling. It is all clinical based. And so we encouraged sites to engage the vast number of people that are in the ED, and that includes physicians, includes all our nurses, so champion nurses, charge nurses. It includes the respiratory therapists, pharmacists, anybody who could potentially be seeing these children and maybe having an extra trigger of saying, this child could be eligible. Let's get this person into the study. Those people will actually, some of the US sites have mentioned that it is invaluable to have our full healthcare team involved in the enrollment.
Thanks, Graham. We've discussed this with some of the other study PIs, like our own Kusum Menon, looking at steroids in septic shock with their SHIP study. So we're going to be co-enrolling those patients in both studies if they're both eligible, and there's no conflict in co-enrolling in both studies.
Okay. Well, that is great. Thank you so much for that presentation and this discussion. We really look forward to this trial and the findings. if there's anything else that we need to know about, I'm sure you will let us know. Fuad, what's the actual date that we're starting the enrollment?
Probably late fall, early winter, as we finish the REP and start getting set up.
Great. All right.
Just a shout out to our ward champions also. We'll need a lot of support from the wards, the oncology groups, the surgeons, the OR. So we can't do this study without the support within the wards and the ICU. Great.
And I echo Roger's comment fully. This is an amazing study and a really fantastic presentation. So thank you all, and thank you everyone for your attendance today.